Hi, I'm Matt Hawkins, and I'm the CEO of Waystar. And I'm delighted and honored to have this great panel discussion today with three experts who are insightful and really good people. I'm grateful to introduce Jim Bonesack, who's the Chief Revenue and Strategy Officer at TransUnion Healthcare. Hi, Jim. I'm going to ask you to introduce yourself here in just a moment. And Dr. Caroline Carney, who's the Chief Medical Officer at Magellan Health, and Lisa McLaughlin, who's the co-CEO and co-founder of a business called Work It Health. And if it's okay, I'd like to turn some time to our panelists just to offer a brief introduction of you and your background and what got you excited about being in healthcare, and perhaps just to humanize all of us, a fun fact, something that you enjoy outside of healthcare. So first, Jim.
Well, thanks, Matt. No, I appreciate the opportunity to be here and kind of share perspectives from myself and TransUnion Healthcare on this super important topic. About me, I'm the Chief Revenue and Strategy Officer, as Matt mentioned, at TransUnion Healthcare, a division of TransUnion. You guys want to know is one of the three bureaus, but a data, information, and insights company, and specifically focused on healthcare. I've been in healthcare for 20 plus years of my career. Early consulting, then on the commercial side, mostly around data analytics, decisioning platforms, as we call it. As it relates to what I do outside of work, as Dr. Carney said, not a lot. I have three kids, live here in Dallas, like to play golf, played through college, and don't get to play as much as I used to. So it's always a challenge to try to find the time. But thanks for having me.
Yeah, great to have you here, Jim, and we look forward to your perspective today. Next, we'll ask Dr. Caroline Carney to introduce yourself to the group as well.
Thank you, Matt, and hi, everyone. Thanks for joining the Emids Summit. I'm Caroline Carney. I serve as Chief Medical Officer for Magellan Health. By background, I got to this through a little bit of a circuitous route. I am a clinician. I'm a board-certified internist and a board-certified psychiatrist, and still practice in an FQHC where I support a behavioral health care program. I'm doing that because I really want to know and understand what our clinicians are facing as they see patients every day. I came into healthcare probably with the same desire that many do, which is to help people. And in fact, earlier this week, had a discussion with my CEO telling him that from my chair, what matters is that every day I know that someone's life has changed in some way because of something that we did. So that keeps me passionate about what I do and makes me want to continue. I also probably don't have a lot of free time. I'm the mom of three. On weekends, I find myself now judging speech and debate tournaments. Wow. And I love to get in the pool and swim. That centers me in mind and body both.
Wonderful. Well, we're delighted to welcome you, and we look forward to your perspective as well today. Next, let's turn to Lisa McLaughlin, who again is the co-CEO and co-founder of Work It Health. Lisa, tell us about you.
Yeah, it's great to be here. I also have a trifecta of children at home. So we're many of us have three children. That's a tie. So my background is in clinical informatics, and really I've done most of my work at the intersection of social work and IT design and product. And so in my role at Work It Health, I lead our clinical programs, so all the work that we do to design virtual addiction care platforms. And in my spare time, I spend a lot of time rock climbing indoors now that I live in Michigan. Wow. We started the company in the Bay Area where there's a lot more outdoor climbing, but there's fine indoor climbing here in Michigan. And I do that quite a bit, as well as keep up with performing arts for my kids are the big draw. So a lot of theater shows and young actors budding in their creativity, which I enjoy a lot.
I love it. Thank you very much, Lisa. And one of the things that I truly appreciate about working in healthcare is the truly fantastic people that are committed to improving healthcare, providing access to healthcare services for people that often don't have it, and generally working to improve the way that healthcare is delivered in the United States and around the world. And each of you are examples of that. And so I look forward to a great discussion today. Today, we're here to talk about the important topic of social factors that influence a person's health. And I can't think of a better group to have this conversation with. These are often referred to as social determinants of health. And as you may know, social determinants of health have a major impact on a person's health, well-being, and quality of life. Examples of social determinants of health include safe housing, transportation, where a person lives, education, job opportunities, and income levels, access to nutritious foods, and availability to participate in physical activities, safety, discrimination, violence and crime, the avoidance of all of those things influence a person's health, pollution and air quality, water quality. And then certainly another major factor would be language and literacy skills, the ability to even understand information when it's being presented to them. And so we look forward to talking about all of these factors and gaining insight from this wonderful group of panelists. If you don't mind, I'd like to start with a question for the group, and I'll ask the same order that we introduced each other to the panel. I'll first ask Jim, if that's okay. There's quite a proliferation and a lot of dialogue going on about novel solutions and partnerships coming to market. From your vantage point, Jim, and with regards to social determinants of health, what do you see working? What is not working? And then what are you excited about in this important healthcare topic?
A big topic, obviously. A lot of, I think, buzz and interest in the application of social risk and social determinants of health as it relates to how we can lower cost, how we can improve health and wellness, and those kind of aspects. And I think there are a lot of newer companies that are starting to innovate around those areas. And as we look at it, there's an ecosystem of sorts forming. Mm-hmm. Everything from the ability to understand that risk to then combine it with clinical data from a utilization perspective, member rosters, et cetera, begin to segment that beyond the, kind of last couple of years of population health, just around a disease state, around utilization patterns, around cohorts in different geographic areas. And I think supplementing as we look at the social risk factors against those efforts that are already in place, we're in the early innings. And I think that some of the legacy practices around data capture and data appends to get that data and keep it fresh and relevant have been challenges that are not working. So things like in-home visits to assess, the age of the home, the number of rooms in the home, the number of people in the home, those kind of aspects. Do you have a car? Don't you have a car? Well, okay, let's not do it there. Let's ask a clinician to ask just one more question. It's like a clinician doesn't have time to ask just one more question about your transportation availability. They need to, triage clinical care and other. Their time is better spent there. And so I think some of those older ways of capturing kind of broader social information need to be and are being relooked at with the availability of so much data as we interact across this new digital ecosystem in the world in which we live. We sit on a mountain of that data. Luckily, both we have the bureau data, as many know, that we're one of the 3 credit bureaus give you credit scores, and that's super deep and interesting around your financial situation. But TransUnion's unique in that we also own a public record data company that has event-driven data. So that's data that's captured when an event occurs, such as when you move. I get your updated address and contact information from your utility connections, which is different from then hoping that you update your bank or, update your employer, or the last person you update is your insurer. And so how do we get that data in the hands of those folks that it can be most actionable and to the right parties? And I think one of the other things we're seeing is the payers are on the leading edge of much of that work and thinking about that. They've got some of the right infrastructure and already the actuarial kind of mindset. The life sciences guys are kind of in the middle. and that they're data starved and want data for different purposes around supporting people on staying on their medications and those kind of things. And last are the providers, as the value-based care, kind of conundrum continues to be a hot topic. So we're focused on, but there are some unique ones out there that are leading in terms of bringing this data together and being able to take action on the data. And then the question becomes, where do you start, right?
Yeah.
Okay, so now I've got a better understanding of the social needs of my population. What programs do I start with, and where do I intervene? And so I think some of those things are forming, which are exciting. And I think that data, the data insights and the availability of data is something we could all start to understand a little more versus sending out social workers to do surveys. Like, I just feel like it gets stale quickly and it's less actionable.
You've highlighted several important thoughts, and thank you very much. Let's turn to Lisa. Oh, excuse me. Let's go to Lisa first. I went out of order. Pardon me. Let's go to Lisa, and then we'll come to Dr. Caroline Carney. So tell us your thoughts, Lisa. What's working? What's not? And what are you excited about?
Yeah, so I think, there's always going to be a future for social work. With that training, I'm certain of that. But I think, one of the things that we're most excited about at WorkIt is the idea that now we're finally in the first position we've ever been in history to treat the Medicaid population the same way with concierge care that we've been treating commercial populations. We've just never had this ability to have these kinds of optimizations through technology of clinical workflows, of all the things that have really been bearing down our clinicians and not allowing them to actually have any real, bedside or webside manner with their patients because they've been caught up in the wrong activities. We're finally able to do that in a way that's so powerful because it gets to the real equity issue, I think, around this, which is access. In our space, because we work in addiction, there is a need for data, and then there's a need for data walling, right? You have people that need confidential care that are doctors and police officers and don't really want you to use their information and are never going to come through the door if that's the requirement at the baseline. And with these tools, I think we're in a position we've never been able to have before to provide multiple pathways into care that are not always trackable. So some of them, it's great that it's trackable. And sometimes what we need is that pregnant mom who's still using to feel like there's a safe way to pick up the phone and talk to a clinician about what's going on with her without being afraid that that data is going to end up in the hands of CPS, or before she even has a shot at reducing her alcohol use, she's going to be in a compliance program. So I think one of the things that we're most excited about at WorkIt is the ways in which we can design care using technology to figure out those preferences, like all that we're able to do with metadata and in these systems to figure out this person really needs privacy. This person has no money. This person will have a really hard time getting sober because they have a domestic violence situation in their home. Speaking of social determinants, and we can get that information where it needs to go, to their doctor for the visit itself. We know not to necessarily send stuff to the home because, partner doesn't know you're trying to get sober, things like that. I think we've never nailed that in healthcare, and a lot of people have been untreated as a result. And so those things are the most exciting to me, is the ability to tailor care and then extend it and democratize it to the masses in a way that, we just have been bad at in healthcare traditionally because of the payment models, because of the different ways we've been forced to be incentivized to make money and to have sustainable businesses. And I think there's hope for, possible, financial models in Medicaid that are actually sustainable.
Yeah, thank you for the real life examples that you're providing, by the way. What I'm hearing is acknowledging that social factors absolutely impact healthcare. And it's good that we're at the stage that we are acknowledging it, and we're sitting on this potentially mountain of information and trying to figure out how we apply that becomes super important. Dr. Carney, tell us your thoughts on what you see working, what is not working, and what excites you about where we are at today.
I am really excited about where we are because of the recognition across payers, across government agencies, across clinicians. Uh, Everyone involved in care is now talking about this issue and paying attention to this issue. So we have a lot of smart people trying to solve for everything that we encounter in that patient journey or the member journey, which I think is really critically important to get this right. We have to understand from that individual's perspective all of the kinds of things that Lisa talked about are happening. But we also have to understand what are the things that work to help fix those. So the kinds of supports that we see, I think, are really important, whether those are relying on predictive analytics that are better than they ever have been before in helping us not only to find individuals who are the most affected by the social determinants, to really linking those individuals to the right kinds of services, such as what we're doing at Magellan is figuring out of all of you, which one will respond better to a text message versus working in an app versus wanting to still have that telephonic conversation with the care manager. And so everything isn't created equally. And we really are seeking to transform that predictive data into an actionable outcome. I agree with Jim that I think the payers are sitting at the apex of so much information that it's really we're very well positioned to be able to use the pharmacy claims coming in, the medical claims coming in, all of the enrollment information that we get, even where an individual works or what kind of job they may have inside of that we see in data. It all blends together to create that model ultimately, or fill that model in a way that we can be actionable. I do think that part of what is not working is as solutions for social determinants become monetized, I worry about competition. And so which group will what provider use to help them solve that issue? And the reason I worry about that is because at the end of it all are those providers in the community who are helping to solve for these things. They'll be the ones who are most impacted and we need to make this simple in a way that we can facilitate all of the solutions back to getting care for the member.
Thank you very much for that. I'd like to just follow up a little bit on some of the items that you've mentioned and maybe and ask a few follow-up questions. So acknowledgement that social factors are very important, the ability to gather data. We've never had more technological capability than we do today to gather information. It strikes me that a lot of the modern electronic health records don't necessarily allow us to capture the full complement of information that may be helpful in delivering treatment or care to an individual. It also strikes me that a patient may walk into a location to get a health service and not necessarily even know information about themselves that may become really important in the delivery of that care. And so I heard Lisa talk about workflows, and I heard you mention, provider, thinking about the provider and how the provider is impacted by, all of this potentially inflow of information. I'd love to get your thoughts on where do we go next? It's clear that data and collaborations are quickly changing the landscape, but what are other factors that inhibit our ability to actually begin to use social determinants of health in a clinical level and broadly? What gaps remain? And let's go back to Jim to get your thoughts on this.
Yeah, I think those are excellent points, Matt, and a good question around how do we deliver that, as Dr. Carney said, that actionable information to the right party who can take the action. And thinking about, we sit at the intersection of HIPAA meets high tech meets this FCRA stuff that I have to deal with, and CFPB and
Yeah.
consumer privacy and the online digital stuff. And I mean, you start to, the California privacy laws, et cetera, all of those things become very relevant. And I think some, general standardization of definitions of what data can be captured, what data can be utilized, how does that data intersect with HIPAA and the legacy regulations that exist around treatment, payment, and operations, and somewhat to Lisa's point, how is that data identified for the right purpose and is not used for any purpose, such as marketing some pharmaceutical thing or something like that. We're very rigorous around, we call it information for good, and the use, making sure that information is not used for nefarious purposes, but getting it in the right hands of the individuals that, as Dr. Carney said, can take action and actually intervene. And then there are so many organizations that we see, and there are companies forming, in the social work kind of care management arena, these community benefit organizations that are well-funded, typically, right? And are not necessarily deploying their limited resources to the most needy because they're just generically, I'm in Dallas. Off the North Dallas. Okay. But that doesn't get down to the level of Jim Bonesack actually doesn't need support affording his food. It's the fact that the fresh food is not available, or he's not a level of health literate enough to know how to eat healthy. Okay, that's a different intervention. And while I have the greatest of intentions of deploying these dollars raised and doing this not-profit community benefit organization, is it a delivery of fresh meals because of transportation? Is it a fresh food prescription program, which we've enabled for certain individuals that can't afford it? Or is it, a nutritional consult? What are those things that we need to do specific to that area, but then to that individual? So I think those things are starting to form, and they're getting informed by data. But I go back to, it's a bit of the Wild West right now. People doing it different ways, taking different approaches, some probably less efficient than others. And how do we kind of raise all the ships, right, to have a better impact on the most needy and have the best return and outcome?
So on that point, that's really good, Jim. Let me ask Lisa this point. Just in your experience with Work It Health, how much of the information that you would characterize as social determinants of health related or social factors are you getting from a third party, a data source, a bureau source, versus a provider is observing firsthand, or someone in the provider organization is observing firsthand and kind of adding that to the patient's record, or the patient is self-reporting. Can you talk a little bit about that? Because I think Jim's exactly right. It's far more than just what zip code do you live in. It's really at the individual level. Can you talk a little bit about that?
Sure, it's a great question. I mean, I think we have a unique DNA at Work It in that we're a patient-led company. So my co-founder and I are in recovery. A lot of how we designed the data and systems and then Work It was very sensitive to the context. So I would say we have 4 quarters of data coming in. One is from bureau organizations like, pharmacy management to understand if patients are getting opioids in multiple locations when they're coming into care, things like that, EMR data. The next quarter would be actual patient-generated data. That's patients engaging in CBT exercises, engaging in visits, engaging with our applications so that we can see trends, both passive trends where, things like, oh, someone is really using the app. It's Friday night, right? Like we discovered this over time. It's like everyone's at the bar, mother-in-law's in town, she drinks a lot. Like someone is like doing a binge CBT, exercise thing. Like you learn something from that signal, right? And then you have the provider data where the nurse practitioners, MDs, and social workers all see the same data, which is really important on a timeline. So that social determinants data that we capture, most of which is unique to stuff we've built through partnerships with the National Science Foundation or NIH, like everyone can see that like a Facebook timeline so that you can really say, if if we know over here that this patient is using Imodium to try to self-detox, somebody who's from the recovery community would be like, that's not a good idea. And sometimes even we have to educate our clinicians to say, that's not a good idea. And, you can fill a lot of these training gaps that when you have those 360-degree views, you get that you would never get before. And then I would say the other quarter of data that we're getting is a lot of the consumer data, the consumer marketing data on the front end of patients coming in through new pathways. So we do a lot of work around finding Facebook patients where they are, or on Reddit, or in the corners of the dark web, and sort of really meeting them where they are. Yeah. And then introducing the service and say, hey, we're in recovery. It's okay. It's safe to come in. But then we know a lot because we have that type of data too. So it's really like you're looking at a really complex multitude of sources that you have to marry together. But I think at Workit, we've been able to really have like 3 North Stars that help us entangle and, pay attention to the right things there. And one is like design thinking, right? Is this like this baseline of, does this help the patient? Does this help the patient? Is this what the patient needs? And then, is this data safe? Like, to Jim's point, like, are we really good stewards of this data? Like, or is this kind of scary that we have certain pieces of data? And then actually the clinician data, always to bring in that science and evidence-based perspective to say, yes, it's great that we have this community and fellowship of people in recovery, but we need the doctors in the room to say that this combination of activities, like somebody combining in our space benzos with a certain opioid, like as a way to self-detox, that's not okay. Like, that needs to be escalated. So I think over time you get algorithms, hopefully in the future, where we're escalating the right things from all those sources to the providers, and the providers then also have really attuned training to read that, because I think there's a lot of digital literacy gaps. Sure. With providers just like being overwhelmed by all the data that they're getting. Like, they don't have enough time to treat, let alone like do a data science project on their own patient. Sure. So it's a tricky blend, but it's so exciting. We've always had those silos and those care gaps that everybody like fell through, and they don't really have to exist anymore. We can change them.
Yeah, I mean, part of it is absolutely an algorithmic exercise to predict and then potentially alert providers, or somehow let providers know in a way that doesn't, going back to Dr. Carney's point, doesn't overwhelm the provider, but it gives them enough context to appropriately engage with the patient. I'd be curious, Dr. Carney, from your perspective on the same topic, what sources of data do you use? Again, third-party bureau sources, self-reported from the patient, identified by the provider, or othered. And could you talk about how you're beginning to gather that data, and then where do you store it? How do you utilize it in day-to-day work?
Sure, I would love to talk about that. And Lisa, some of that actually is already here and in play today, so I hope to touch on that. We use a company called Arene, which is a data science company that is in the space of helping us do predictive modeling, particularly when bringing together pharmacy data, medical data, behavioral data, and blending it with anything else we can get our hands on. So that might be electronic monitoring data, might be genetic data, it might be third-party sources. So we blend it all together and come out with the kinds of reports that we ask them to run for us. One of the really interesting things that we saw in a Medicaid population in Virginia is, despite all of that best high-tech predictive modeling, Arene has shared with us over and over, what enhances it the most is the old-fashioned health risk assessment that our care managers are doing on the members that they're able to connect, because that's when they get the real stories. That's when they get the kinds of things that really are front of mind for them and preventing them from getting the kind of care they're getting, or the stories that talk about the violent home they may live in, or whatever else is going on. So then we take all of that information together and stratify it into different levels of risk and different kinds of outreach. and really kind of try to align which clinician or which non-clinician may reach out to the member to help them with what would be top of mind for them and based on where their risk is. We look at rising risk individuals who may need gaps in care closed before they become high risk individuals, or the high risk individuals who may need very different kinds of interventions along transition of care, along getting medications to them, whatever it may be. It's really something that has to be aligned to risk. I'll give a really important real world example for two programs that we have. One is called Whole Health RX, and it pulls together all of the kind of data that I talked about, including prescriber information. And so I can find out based on my member and who their prescriber or prescribers are, who's on that dangerous combination of opioids and benzodiazepines and a sleep medicine plus 10 other medicines for chronic illness, and whether or not their providers even know or understand what that full medication list looks like. So we do academic detailing with pharmacists going out prior to COVID, going into practices, on COVID now, doing this over Zoom to offer that friendly helping hand and say, hey, let me help you with this management. Sorry, I'm somehow getting a phone call while we're doing this. I'm really sorry about that.
It's fine. You're busy, but we appreciate it.
We have found remarkable changes in utilization post those kinds of interventions, and gap closure, closing of medication gaps, closing of polypharmacy gaps, ultimate reduction in emergency room utilization and inpatient care, because we help holistically make that member. I am so sorry. Don't know why this is happening all of a sudden. So that's one. And the second that's really top of mind for me right now is our suicide program. So in the very same way, we use those data and model against individuals who have the highest suicide risk and proactively do that kind of outreach to the member and to the provider to try to bring them into care. And we put an app into their hands that we can engage in. I am so sorry.
You're fine. You're fine.
I will I think I need to turn my phone off. And so we're using that information to find the individuals who are at highest risk and going into the communities to work with those individuals, whether those might be peer counselors or recovery support navigators. On the back end, if those individuals end up in residential care or come into an inpatient stay because of suicidal ideation or an attempt or a gesture, we're able then to better target around discharge planning to address the social determinants that would prevent them from getting the follow-up behavioral health care that they need. And so the data drive it, and they tell us where to look, they tell us what the right kind of interventions are, but it's really up to an individual engaging with the health system and engaging with that member to make the intervention happen. And I can tell you time and time again, it works.
That's wonderful. And thank you for the real world examples. They're very helpful as we start to understand and appreciate the benefits of social determinants of health and how they can show up in at the individual and population level and improving the quality of care. These are noble things. If we can prevent a suicide, if we can discharge someone safely to a home or to a location where we know that there's ability for them to feel safe, so to speak, it's wonderful. We're down to our last question or two. I'd like to ask you, amongst all the benefits that you see in practice today, Lisa and Dr. Carney and Jim, what do you think the biggest benefits of social determinants of health are? Savings. I heard you say reduced burden on some services and utilization of certain resources within a hospital or within a care setting. Is it better access and better democratization of care? Is it improved awareness that can improve quality? I'd love to get your perspectives, Jim, Lisa, and then Dr. Carney?
Yeah, I really think it's the deployment of we all have limited resources, regardless of the position we sit in the broader industry, and it's how do we allocate those resources the most effective way. As you mentioned, we're all in this healthcare space because we like to help people, and we want to feel like we're having the biggest impact. For too many stories of clinicians saying, man, I can only treat 30 a day in the clinic, but like Dr. Carney, I now can impact huge, massive populations in the role that I'm in. And that's a better day for me and an outcome. And so I really think it's, yes, those metrics to measure is reduced readmissions, reduced, ER utilization, increase in PCP visits, better clinical outcomes and metrics around health and wellness. All those are the results and how we measure progress. But I really think it's about just getting the resources to the right people for what they need. And as Lisa said, in the right way in which they want to engage. Mm-hmm. That's important, right? Satisfaction for me as a patient, you as a member, as an employee, whatever that role is you're wearing at the time. I think those things matter. And I just think the use of data, our recognition that these things broader than clinical care really do have a major impact on how we behave, how we interact with the health system, and how we live our lives. Just that recognition is huge, and we're making huge progress towards it. But it will accelerate, and I think it will get better sooner rather than later.
Thank you, Jim.
For me,
Lisa,
yeah, sorry, I got excited. For me, I think it's cure. I think that it's cure from these conditions, because when we see patients come in and they've been going through this Tower of Babel of care navigation to directory to dead phone number to this, we don't do that at WorkIt. It's like we ID the patient and we treat them. So there are no care gaps that have to be filled, right? That's what we can do with Instant. That's what on demand is like for Netflix. That's what it's like in many other industries, and we have that now. So I think we've left people in a crappy position to go down some wormhole and find a way. And I for one, have over 60 dead friends who died between, when I got sober in 2002 and today, because we sent them down the wormhole and we made them call this person and then that person and then this navigation thing and then that. And we lost them, in that hole. And we don't have to do that anymore. This is a hospital, as far as going forward. Care improvement.
I love it. Thank you. Dr. Caroline Carney, quick thoughts.
I would echo what was just said. I think this is all about finding that social determinant that is preventing the individual from accessing the right kind of care to really help them get over a behavioral health hump, a medical hump, those things that are really blended together. The stories that I could share from clinical practice are so sobering and really influence what we try to do in our day-to-day work in care management programs and in contracting with providers and agencies that are developing and deploying the social determinants treatments. I can't say enough how important it is to have the right diet, to have transportation, to have medications in your hand, to have the right list of medications, all of the things that typically in the past haven't been billed for or covered in traditional insurance. We have to do those sorts of things. And we are, and it's incredible.
Thank you. What a wonderful panel discussion. I thank each of you. This is a call to awareness and a call to action, and this hopefully will stimulate a lot of thinking and action. So thanks a lot for the wonderful discussion today.
Thank you.
Thank you.